Well, good afternoon, everyone. This is Brian Robson, the Medical Director here at Healthcare Improvement Scotland. And welcome to this, the third in our QI Connect series for 2018, the 42nd since our series began. As you know, QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the fields of improvement, integration and innovation. We've designed these sessions to be short, accessible and recorded to allow access at a time that suits you. I'm now going to pass you over to Jennifer Graham, who's going to talk us through the technology and how we're going to be interactive this afternoon. Good afternoon, Jennifer.
Good afternoon, Brian, and good afternoon to all of our QI Connectors on the session today. So I just have a couple of quick housekeeping slides to get us started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. And if you are having any technical difficulties, such as not being able to hear the presenters speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be an interactive learning experience and lots of fun. So we do encourage you to use the chat function to share any questions, comments or ideas through the talk. And there will be an opportunity for some Q&A at the end of the session. We'll also be sharing hyperlinks within the chat function to any resources mentioned by our speakers today and circulating that to you all afterwards. So with the chat function, if you could click on the speech bubble you can see circled in red at the top right-hand side of your screen, type in your message and send. Now, if you could send your messages using the All Participants option, that would be great, and then we can all see. Now, we did promise that today's session was going to be fun and interactive. We're keen to find out where you're joining us from today. If you could please select the annotation tool circled in red here. Oh, there you go. And then click on the arrow icon, and then select the country you're joining us from using the arrow. And we do know that there can sometimes be a slight delay from colleagues joining out with the UK. So we can see lots of people joining the UK just now. Welcome to Catherine. Oh.
Yeah, great to see so many people joining, Jennifer, and we'll just give it a moment or so, folks. And I can see Tracy in the chat box saying hello. Alistair Philp is trying to persuade us that it's sunny in Edinburgh. We're in Glasgow and it's glorious here. Good to see so many folk joining. Hi, Gisela, welcome. Great to see other people joining. We're certainly very Scotland heavy today, which is great. Hi, Paul, over in the west coast of the US. Absolutely super to see so many QI connectors. Hey, Wendy, I'm not sure you're up there, but if you are up there, it's pretty cold up where you are. And Catherine's just finding her way across. Absolutely great to see the QI connection all over the world. Great. Welcome, Molly. Super to see so many connections. Jennifer, it's absolutely wonderful to have so many QI connectors join the series. And we've now broken through the 700 barrier. We're now at 703 organisations who sign up and connect in with QI Connect, which is quite fantastic. And just to keep us all on our toes and on our keyboards, Jennifer, we're going to have the competition. So, folks, as you know, we like to show this slide here and invite you to be the first arrow to go onto a particular flag. We have 54 countries now joining QI Connect. I'm going to shout out the name of the flag, and you're going to use your arrow function, and the first person's arrow that gets on the correct flag wins a wonderful prize. And the flag today is the United States of America. Oh, Kate. Fantastic, Kate. Great to see you there. Well done. You were straight on the money there. Great to see. Yeah, it was an easier flag than normal, but absolutely great to see Kate Ocker, who is a research nurse at NHS Greater Glasgow and Clyde. Absolutely fantastic. Well done. Fastest fingers in town. And your wonderful prize, as ever, is a QI Connect mug. So congratulations, Kate. Oh, there you go. Just Kate telling us in the chat box that she should get that one. Your husband's from the US. Well, yeah, good job. Well done. Great to have so many QI connectors, and please keep the chat coming, saying hello to QI connectors from all over the world. And I'm absolutely delighted to say that not only do we have 54 countries, but these are the logos from the 704 organizations. We now run to 21 slides of your wonderful logos from all over the world. Absolutely amazing to have so many people join us across health, social care, education, criminal justice. We have policy leaders, we have government leaders, we have people from third sector, from social services. It's absolutely tremendous to see the reach of QI Connect. You're all very welcome. And I'm always delighted to highlight that the whole of NHS Scotland joins QI Connect, and it's great to have so many of our colleagues join us live as well. And for the first time, delighted to welcome another 10 new organisations from across Scotland and across to the west coast of the US. Great to have the Anstruther Medical Practice, probably referred to as the Ainster Medical Practice up in Fife, our colleagues in the West Lothian Partnership from outside Edinburgh, the Cystic Fibrosis Foundation, and our colleagues in the ambulance service in South Central, and Sibley Health, which is from the west coast of the US. Great to have so many of you join us. Welcome to QI Connect for the first time. We're always delighted to shout out to our universities, and we have 62 universities from across the world joining QI Connect on a regular basis and using the resources of QI Connect. It's absolutely wonderful to have that connection. And we're delighted today to have the cohort 7 of the Scottish Clinical Leadership Fellows who are all gathered together through in Edinburgh. I was with them this morning. They're finishing off their learning day today by joining QI Connect. So a big shout out saying hello to all of our colleagues and friends in the Scottish Clinical Leadership Programme. Welcome to you and our fellow over there from Healthcare Improvement Scotland, Katrina Ingram, and her colleagues. And we always point out that the QI Connect is a recorded resource, can be used time and time again. Our colleagues in New Zealand pointed this out to us when we started the programme. They found it a very useful resource to have recorded, and they're delighted to say that all of the recordings are free and available on the Healthcare Improvement Scotland website. Please use them freely and share the learning again and again. And we're always delighted to give a shout out to the International Society for Quality in Healthcare, whose fellowship programme use QI Connect and our resources as part of their accredited fellowship programme. And this is the second year of our partnership with the Health Foundation and the Q initiative, where we're developing across the United Kingdom a cohort of quality improvers. And we work with NHS Improvement in England on that programme. Delighted to have that connection and have so many Q fellows on the programme too. And a big shout out to the members in Scotland as well. And delighted to have these lovely photographs of the small but perfectly formed QI Connect team. So you've heard from Jennifer earlier. We have Michelle De Felici working on registration. We have Jess Yule running the programme and registration also, and Carmen Forrest, who does all the certification. And great to have Alex Sterling on Twitter and resources here with us in the studio, aka my office. Great to have that team working on QI Connect. And we'll be delighted to introduce Dr. Gregor Smith a bit later on in the call today. Gregor is the Deputy Chief Medical Officer for Scotland. based in the Scottish Government and a general practitioner by background, and Gregor will be our first questioner later today. Remember, please tweet as you learn, hashtag HISQIConnect, and follow us at HISQIConnect. So without further ado and further introduction, let me just pass on now to our QI Connect speaker today. Our speaker today is a lifelong agent for change and advocate for the voice of people in service redesign. He holds an undergraduate degree from Dartmouth and a medical degree and public policy degree from Harvard. He was the Chief of General Medicine at Harvard and Massachusetts General Hospital for almost 30 years before moving from Harvard to Dartmouth College. Professor Al Mulley is Managing Director of Global Health Delivery Science at Dartmouth, New Hampshire, where he's created partnerships around the world to build the capabilities essential to achieve sustainable healthcare economies across the world. He's been a visiting professor and health policy consultant for governments and healthcare institutions in North America, Europe, Asia, and beyond, and is a visiting professor at the University College in London, and was indeed the first King's Fund International Fellow back in 2010. Al's work in shared decision-making and the shared decision-making programs to support patients and clinicians in the decision-making roles has been outstanding and instructive for many, and we're very grateful to have Al with us today. Good afternoon, Al.
Good afternoon, Brian. Thank you very much for that generous introduction. It's a privilege to be back in conversation with you and colleagues across Scotland and across the world convened through QI Connect. I'm really grateful. Before we start talking about realistic medicine and the provocative question, whose decision is it anyway, I want to give you a little bit more background about myself so that you can understand the biases that I'm going to bring to the conversation over the next 50 minutes or so. When I was an undergraduate at Dartmouth, as you heard from Brian, I thought I wanted to go into medicine, but I was relatively unformed at the time. And in December of 1968, I read a paper in Science that had just been published that week called The Tragedy of the Commons by Garrett Hardin. And it's a simple parable about how people following their own interest in a well-intentioned way and caring a bit about those around them, a good bit, could lead to dire circumstances if they didn't recognize the problem of common resources and how they might be governed. The simple parable was about a pasture and people being able to put their sheep and cattle on that pasture without any kind of agreements or governance agreements. I was fascinated by it largely because we had just passed Medicare. This was 1968. We had just passed Medicare and Medicaid in the U.S., a pale version of a step towards equity compared to the U.K. 20 years earlier. And I had a very strong interest in the National Health Service, largely because of the circumstances under which I grew up. My parents were both immigrants, my mother's family from Poland, my father's from Newfoundland. I grew up in the most deprived community in Massachusetts, just across the river from Massachusetts General Hospital. I tell you that story, one, to express how grateful I am for the opportunities I've had, but also because it's very relevant to a key component of a new model of care, particularly primary care, that I'm going to be talking about later on. When I read the Hardin paper, I decided that I'd only go to medical school where I could study economics and policy while I was studying medicine. And as you heard from Brian, I did that at Harvard and stayed for 40 years. I learned a great deal from economists. Probably the most important thing I learned is that you cannot judge the quality of a decision made in the face of uncertainty by its outcome. Bad outcomes follow good decisions, and good outcomes follow bad decisions. And there are enough bad decisions in the world, including in health and social care, that that's a very good thing. The quality of a decision is all about the time and attention one gives to thinking about the alternative options that are available, the important outcomes, both good and bad, what the relative likelihood of those outcomes might be. But even when you go through that exercise, you're still not done, because you also have to consider carefully what those outcomes will mean in the lives of the people who live with them. So you can see from that story, one, you can anticipate the biases I'm going to bring, but you can also see why realistic medicine really resonated with me when I read it after its publication as part of the Scotland CMO's report for 2014-15. If you look at the 6 elements, realistic medicine, can we change our style to shared decision-making, build a personalized approach to care, reduce harm and waste, reduce unnecessary variation in practices and outcomes, manage risk better, and become better improvers and innovators, they all relate to this question about decision quality in one way or another. I made it a point to spend a good bit of time with Catherine Calderwood and Gregor Smith in the ensuing year, and had the opportunity to be quoted in the follow-on report the next year, describing realistic medicine as a bold pronouncement, a bold decision coming from a chief medical officer. I admire the courage that it took to talk about those 6 elements with such clarity, and also to challenge assumptions that prevail throughout health and care systems across the world in doing so. So the next slide is going to appear several times during this conversation. It's actually a picture of where my wife Margaret and I get our primary care. This is Dartmouth Health Connect. It's a primary care model built upon experience in the U.S. with a model that you may have heard a good bit about called Atlanticare Special Care Center. Again, we'll talk about that later. At this point, I just want to introduce the people in the pictures, at least some of them. In the top picture, the man to the left leaning in is Joel Lazar. Joel is a close colleague here at Dartmouth and is co-editor, along with Jean Nelson and Paul Batalda and Margie Godfrey of Value by Design, pictured on the right. He's also the medical director for Dartmouth Health Connect. To his left, on the right side of the picture, is Tyler Hanna. Tyler Hanna is the health coach. The woman that we can't see, who has her back to us, is a patient. We'll come back to this later. In the lower left, the picture is of what's called a huddle. And the person most prominently pictured there in the blue shirt is Rushika Fernandopoul, who Dartmouth partnered with in building Health Connect just after I arrived in 2011. Before we go further in challenging assumptions, and this is about challenging assumptions, the first picture that I showed you was an attempt to indicate that, yes, we're going to challenge assumptions, but this is not theory. This is practical. There are ways to implement the challenges in new models of care, particularly at the front lines of care. So I first began to work with Jack Lindberg in 1982, right after a paper was published in the New England Journal of Medicine with the lead author being Clem McPherson. So my collaboration with colleagues in the UK and with the NHS dates back many years now. And what that paper demonstrated was that the practice variation, the 4, 6, 10-fold variation in per capita rates of surgical interventions in New England was also going on in the Midlands of England and in Norway. I'll tell you later a story that gives you a sense of why I was so interested and went up and introduced myself to Jack in 1982. But for now, let's just follow this history. By 1996, Jack had taken the same methods of working with Elliot Fisher and other colleagues at Dartmouth that he had used to study small area variation in relatively rural northern New England and applied it across the entire United States, creating 306 hospital referral regions, aggregating over 3,000 individual hospital market areas. And the astounding finding there was that within our Medicare population, we were spending 3 times as much in some cities like Miami as we were in other cities like Minneapolis. That raised a critically important question, and it took 7 years for Elliot Fisher to put together a study that answered that question, being, if we spend 3 times as much, do we get better value? Are there better outcomes? The answer was no. With higher intensity and cost in places like Miami, there were no better outcomes in mortality and function. It was more difficult for patients by their own reports to see doctors with longer wait times. There was more difficulty for doctors in their reports to admit patients to the hospital and obtain referrals. And doctors also felt that the relationships were poorer in areas that had this high intensity, high cost care. What were the sources of waste and harm here? Well, we concluded after years of study that it was failure to deliver effective care safely, and that contributed to a great deal of outcome variation. We'll talk about this in a moment. Second was overuse and underuse of preference-sensitive care. That is care that depends very much on how a patient feels about the necessary trade-offs between good outcomes and bad outcomes and their probabilities. And you can think of this simply as uninformed clinical decisions. If it's easy to avoid ignorance on the part of a clinician about what matters most to the patient, and easy to avoid ignorance on the part of the patient about what the gist of the trade-offs might be, we can call that uninformed. And the insight here is that it's those uninformed decisions at the front lines of care that lead to uninformed investments in health system capacity. And that leads to overuse of what you could call supply-sensitive care. However many hospital beds you build, there's going to be enough discretion in the decision-making for most of them to be filled. However many specialists you train, similarly, there's enough discretion in the decision-making in order for them to stay busy. Now, at this point, a lot of people in countries around the world, particularly in the UK, think this is a particularly American problem. In 2010, thanks to the efforts of Phil De Silva and Muir Gray, the NHS Atlas was published. And if you look carefully at those early results from 2010, it's pretty apparent that this is a universal problem. We've got the largest market-driven healthcare in the economy with these threefold differences, and in the largest plan, tax-funded, free at the point of service, healthcare economy, at least the England portion of the UK, we have threefold variation among 152 PCTs in 2010 in per capita costs for cancer and heart disease care. And after the 7-year funding stream of the NHS plan, beginning in 2001, going to 2008, at the end of that, when they had invested a great deal in increasing capacity to do procedures that had long queues, long wait times, cataract extraction and surgery and stenting for stable angina, there was 8-fold variation in the per capita rate of stent placement for stable heart disease within the NHS. And you can see there was even great variation within London. Now, in the United States, a decade ago, it was shown in a relatively small local study in Western Massachusetts that 90% of the patients who had a stent placed for stable angina believed it reduced their risk of heart attack and sudden death, despite the fact that there was no evidence for that at the time. A decade later, when there was a great deal more evidence that that was not the case, much larger study across the country, 92% believed that it reduced the risk of heart attack and sudden death. There's just one example of easily avoidable ignorance. Now, the work with the NHS really led to common pursuit of a strategic intent to learn from variation to deliver what is valued. Now, those of you who heard Nirav Shah's wonderful QI Connect session last month may think there's a little bit of a tension here. The title of his talk was Standardization is Innovation, and he talked a good bit about process control in order to reduce complication rates, in order to increase flow, even to get people home after joint replacement on the day of their surgery. I don't see it as a tension as much as a difference in emphasis the two of us are bringing to the conversations at this point. And in fact, we learn from variation in outcomes and costs only by making visible the underlying variation in processes. But what I would add to the conversation at this point is we learn from variation in practices. We learn from variation in per capita rates of intervention by making visible the underlying variation in preferences and making sure that it's the patient's preferences that are driving the decisions at the level of the individual. Now, those two phrases are intentionally expressed in very simple ways. They often raise the question, well, if this is so simple, why has it been so difficult to bring it to scale? Why has it been so difficult to make it part of our health and care systems everywhere? And I'm not going to take a lot of time. I'm just providing this slide now, so we might have the opportunity to come back to it in discussion. But there are conceptual challenges and there are operational challenges. The conceptual challenges include what we choose to measure, and is it what matters among the people we serve? And it also includes how we choose to manage, and do we manage for accountability among the people who must depend upon each other to achieve system success? Now, just a quick headline here. I think because of our training, we tend to trust measures that are highly objective and generalizable, ideally universal. Objective measures demonstrating universal truth is the way you win a Nobel Prize. And that's the coin of the realm in many of the places we've trained. But often when you're trying to deliver value to individuals, which is the only place we really create it, what needs to be measured is highly subjective and highly context sensitive at the level of the individual. We don't respect those measures so much, we don't record them as much, and we don't use them to manage. We have basically an intersection of reductionist measurement and reductionist management. Those are related to the operational challenges. The operational challenges are we're not really trained, most of us in healthcare, to work with teams and to deliver services as part of a team. Certainly, physicians are not, surgeons are not. And in order to overcome this operational challenge, we need to deliver with teams that include new roles designed for engagement of patients and families. And these teams are so different than the generic multidisciplinary team that you see sprouting up in various places that we need to organize not just for improvement, but for innovation. Again, we'll have opportunity to come back to this during the discussion. What does this look like in acute care? Again, I'm going to use the example that Nirav did about joint replacement when we're talking about acute care, and then use that also to move over to primary care. In England, there's a great deal of attention being paid to the model hospital, which was coming out of the Carter Review, working with some 30-plus acute trusts across England, and getting it right the first time, led by Tim Briggs, an orthopedic surgeon, who understandably would have an interest in joint replacement. And here you can see deep wound infection rates vary 8-fold among the acute trusts that participated, and each is traumatic for the patient and incurs additional costs of 50 to 100,000 pounds. The quantity of hip systems within acute trusts vary greater than 15-fold with 1 to 7 brands, and the average price varies 2-fold from roughly 800 to 1,600 pounds. Now again, the answer here is making visible the underlying variation in processes. What processes are associated with the low deep wound infection rates? What are associated with the high deep wound infection rates? This is all Improvement 101. Many of you know it far better than I. But look, this is from the NHS Atlas, and it shows the rates of primary hip replacement procedures across CCGs. And what you see here is basically a 4-fold rate. That four-fold rate difference, that 4-fold variation in rates is very interesting, and we'll come to that in a moment. But first, let's look at what this might look like in primary care, learning from variation in outcomes and costs by making visible variation in preferences, and learning from variation in practices by making visible the underlying variation in preferences. I said preferences the first time, I think, processes and preferences. In order to look at this, I want to start by saying, in the U.S. at least, there is strong evidence that health services that emphasize primary care, including our emerging accountable care systems, have better outcomes and lower costs. But if you look at the variation in primary care, it's stunning, largely because we don't have a lot of evidence to tell us what should the duration of a visit be for a consultation. How frequent should visits be, and particularly follow-up intervals between visits. In the United States, somebody who has long-term conditions, multiple long-term conditions, who has their regimen changed, might be equally likely to be told to come back in 2 weeks, 2 months, or 2 years, and there's no evidence to tell us which is right. I want to focus for the moment here on imaging and test ordering. This is my practice at the MGH. And you can see here 6-fold variation in the rates at which we chose to order images, including MRIs and CTs and nuclear scans and others. Interestingly, in the UK, there's 4-fold variation in the rates at which imaging is ordered across the PCTs, and 4-fold variation in rates of hip replacement. 4-fold in the US, 4-fold in the UK. Now, here's the 4-fold variation in the UK. The cities over on the left, from Salt Lake to Manhattan, are represented by the red dots, and you can see Salt Lake has a 2-fold per capita rate variation over Manhattan. In 2001, Gillian Hawker noticed that there was 2-fold variation in rates in the west and the eastern part of Ontario, and she decided to test the hypothesis about preference sensitivity. She identified about 300 patients who were perfect candidates based on their history, their physical exam, their images for joint replacement. And everybody agreed. The guidelines would have said these people are perfect candidates. What they then did was a brief shared decision-making intervention. Without shared decision-making, the per capita rate in Ontario would have been higher than any of the rates, significantly, in the US. With shared decision-making, the per capita rate in Ontario would have been lower than any in the US. How does this happen? This is a man who was a high school basketball coach. Interestingly, he was at risk for a never event because his x-rays looked identical in both knees, but only his left knee really hurt. He chose to have surgery because of the context in which he lived his life and what the pain did in constraining him both professionally and personally. This woman had equal pain scores, equal images. She chose not to have surgery because of the context of her life. She was able to exercise. She knew the exercise was good for her in maintaining her physical function, and she chose that option. There's a wonderful Peter Drucker quote here. There's nothing so useless as doing efficiently that which should not be done at all. I want you to think about an example that Nirav gave last time, one that I've used frequently. It's not unusual when somebody has a joint replacement, dealing with the difficulty of the re-enablement, who regrets it. We heard a story in one of the teams we were working with in England about a woman saying, I just wish I'd known this was going to be so difficult. All I really needed was for the banister to be repaired. That's the exact example that Nirav used as well in his talk last week. So back to this new model of care. Do we have time to learn what really matters to patients in a 10-minute GP consultation? Do we have time to help them understand the trade-offs, help them understand the re-enablement period that they'll have to deal with if they go ahead with their procedure? And here's where I want to begin to challenge some assumptions. The first assumption is that clinical evidence tells us what is the right thing to do for people in need of health care. Evidence to the contrary, evidence is insufficient. Patient preferences matter in decisions to deliver services that produce value. Very quickly tell you a story. When I was at Mass General, I was attending physician in the intensive care unit, and I was building a database. I was doing some research on intensive care decision-making. I contributed to the President's Commission for the Study of Ethical Problems in Medicine and Biomedical Research in 1981. 2 years later, they published this volume, and that was the first time that the term shared decision-making was used. I was coming back from a family meeting where we were trying to decide whether to do a tracheotomy on day 10 when a patient had been intubated in the emergency room with end-stage chronic lung disease. And as I was going back to my office after what was a really good conversation, I did everything I could to teach my students and trainees on what I'd learned from economists about decision-making. I was wondering how many cases like Mrs. Jones I had so I could narrow the confidence intervals around the probability of her having survived. When I was approaching my office, I had an epiphany. It really didn't matter what the probability was. At best, it was 2–3%, and it didn't matter whether it was 1 in 50, 1 in 500, 1 in 5,000, because the decision was so much more sensitive to how Mrs. Jones and her family felt about where, when, and how she was going to die. The reason that was an epiphany is all of the evidence is focused on telling us the probabilities. The evidence is largely silent on what matters to patients and how different patients have different preferences. The second assumption, healthcare is the delivery of services by professionals to people unable to understand or do for themselves. When much of healthcare, especially primary care, is the exchange of information about what is possible and what is most valued. This is a volume that I produced along with two Dartmouth colleagues, Glenn Elwin and Chris Trimble, during that time that I was International Fellow at the King's Fund. And some of you may have read it. It tells the story about two women who, one had a disease misdiagnosis. She never should have had her surgery. She didn't have breast cancer. There was a mistake in the laboratory. And another, a woman who never should have had the surgery because if she had been told of an option for a woman at her age and stage of comorbidity, could have taken hormone therapy instead of the surgery. We basically said the scalpels are equally sharp. This disease misdiagnosis, this preference misdiagnosis, have equally bad consequences. Some research that I had done with colleagues in Boston illustrate how prevalent this problem is. We gathered women and asked them, as they were facing their surgery decisions, what mattered to them? What were their biggest concerns? We asked them to rank their concerns. There were 12 of them. We then went to their doctors and asked them, is living without a breast one of the top 3 concerns for your patients? For the doctors, 7%. For the women, 71%. These are two men facing the decision about prostate surgery, the condition for which we used in developing this model of thinking about variation. The man on the right isn't terribly bothered by his symptoms. The man on the left is a construction worker. He climbs heights. He has to come down to use the loo. Very, very different contexts. A man on the right, when supported in shared decision-making, is 7 times more likely to choose surgery than a man on the left. Depending on how they feel about the complication of retrograde ejaculation, a man who's really bothered by that prospect is 1/5 as likely compared to a man who's not bothered by the prospect. These are elements of measuring decision quality. The last assumption, higher levels of healthcare produce higher levels of health and well-being for people and populations, when in fact we know increasingly healthcare contributes less to health and social circumstances, including education and behavior. This is a very engaging illustration of that. These numbers can be argued, but this suggests that it's 11% for healthcare, 7% for the environment, 38% for behavior, 21% for the social circumstances into which one is born and live, and 21% for your DNA and biological attributes. If we really want to build sustainable healthcare systems, we need to recognize the opportunity we have to avoid medicalizing social problems. We need to recognize the opportunities to free people from their social circumstances to address the behavioral issues that contribute to their health. And that brings us back to the question of teamwork and that primary care model that I described earlier. This is an interesting reintroduction to that slide. On the right, we have level of training and skills. as high on the left, low. At the bottom of this two-dimensional space, difficulty of the task is low. At the top, it's high. That makes the 45-degree line very interesting. Everything below it is potentially inefficient. Everything above it is potentially ineffective or unsafe. Now, Rob mentioned Taylorism or Fordism, production line work. And if that's a single line, it's very unsettling for everybody, regardless of whether it's the neurosurgeon or the GP, the nurse, the pharmacist, because it looks like there's only one finite spot where you're both efficient and effective. But if we bring teamwork into the picture, it's not a tightrope, it's more of a boulevard. And if we bring measures of teamwork, like Jody Cattell's relational coordination, shared goals, shared knowledge, mutual respect, communication that is frequent, timely, problem-solving, and accurate, we can actually honor it, reward it, and improve delivery of care that's valued as a result. Now, just very quickly, there's a fascinating study done by colleagues here at Dartmouth talking to leadership, both clinical and managerial, clinical and executive leadership, about teamwork. They didn't share with them the Gattell 7 items for the measure, but they did qualitative research interviews. And what they found was that when they talked about teamwork at their level, they recognized the importance of shared goals and communications that frequent, timely, and problem solving, not shared knowledge of interdependencies or mutual respect or accuracy. When they turned the focus to their conversation about teamwork at the front lines, all they recognized was communication that is frequent and problem solving, highly transactional, not relational. This was a model built to be relational. The teams are designed for engagement and learning. Clinicians making highest and best use of their time. Support personnel recruited, not for their experience in healthcare, but for their common lived experience with the patients they engage with, empathic communication skills, trained in decision-making, motivational interviewing, to understand needs and wants, guided by new measures and management tools, and avoiding the substitution of care that exceeds wants, especially when it fails to meet needs. Now, we did this by dramatically reducing by 50% traditional clinical time per patient and using those resources to hire at a ratio of 5 coaches to GP coaches, tripling the amount of engagement time with patients with the same amount of resources. Here are some design principles from a paper that I want to signpost you to that goes into these issues in a good bit more depth. You can see continuous learning from and with populations, co-production by teams of what's valued by individuals, access to information, support, integrated services, supporting the personal agency of all people served and those who serve them, and then mutual accountability among all stakeholders. This is the first time I've used this slide, and it's meant to highlight the importance of the learning front end down at the origin of this two-dimensional space. My colleague Glenn Elwin and his team here have developed really effective measures for rapid time feedback, not so much for research and publication, but to guide implementation of innovative new models like this. So Collaborate is 3 questions, 0 to 9 scale, answered the day after by text message perhaps. How much effort was made to help you understand your issues? How much effort was made to listen carefully to learn what matters most to you? How much effort was made to consider what matters most to you in planning the next step in your care? Now, that's a tool for the GP or the person working with the GP on the clinical team to hold themselves accountable for what should be consistent with the simple rules that are aligned with their intrinsic motivation. Similar, simple measures, simple tools need to be developed and applied from the front lines to system delivery leadership. And if we do that, we can basically achieve micro-commissioning at the front lines and have that micro-commissioning inform the joint macro-commissioning that's necessary in sustainable integrated care systems, with managers and system leaders holding themselves accountable for decisions informed by patients' health and care needs to fund transformation and reallocation of capacity to deliver services. Now, here's another signpost here, but it's really just to remind me that there are wonderful examples of opportunities to avoid substituting by medicalizing social and behavioral problems. Children and adolescents with mental and behavioral health care needs. In our inner cities of Philadelphia, children were signposted for ADH and depression treatment when in fact it was food insecurity. They didn't have breakfast. A colleague, Pat Deegan, tells a wonderful story about how well she was treated with her schizophrenia and how she stopped hearing voices, but went back to her doctor and said, your job isn't to keep me from hearing voices. I have no ambition. I've gained weight. I chain smoke. Your job is to keep me functional enough to have a job of my own. And I'm going to close with a turn to the next session with Atul Gawande by telling a story that some of you, I'm sure, have heard. It comes from Archie Cochrane's memoir, in which he talks about his education at Elsterhorst, the German prison camp, where he was a prisoner and forced to serve as the camp doctor. Another event at Elsterhorst had a marked effect on me. The Germans dumped a young Soviet prisoner in my ward late one night. The ward was full, so I put him in my room as he was moribund and screaming, and I did not want to wake the ward. I examined him. He had obvious gross bilateral cavitation in his subpleural rub. I thought the latter was the cause of the pain and the screaming. I had no morphia, just aspirin, which had no effect. I felt desperate. I knew very little Russian then, and there was no one in the ward who did. I finally instinctively sat down on the bed, took him in my arms, and the screaming stopped almost at once. He died peacefully in my arms a few hours later. I first heard this story from Ian Chalmers and then from Joe Bibby, and they both stopped here. It was not the pleurisy that caused the screaming, but loneliness. It was a wonderful education for me about the care of the dying. I was ashamed of my misdiagnosis and kept the story a secret. I want to suggest that there was no reason for him to be ashamed. He instinctively got the diagnosis right. And the question is, would he have gotten that diagnosis right and instinctively acted that way if he had had the morphia? I'll stop there now and look forward to your questions and the conversation.
Oh, thank you so much. That was absolutely brilliant. And the story from Archie Cochrane, I'm sure many people have similar sorts of stories if they think back through the lens you've just given us. Very, very powerful. Al, thank you so much. We're going to bring, I know you've got some more content that we can go back to there if we need to, but let's bring in Gregor Smith. Gregor is as we introduced earlier on, there we go. Gregor is the Deputy Chief Medical Officer of the Scottish Government and a general practitioner by background. Good afternoon, Gregor.
Good afternoon, Brian, and hello again, Al. It's lovely to hear your voice again today.
Likewise, Gregor. It's lovely to hear yours.
Do you know, before I start, I just want to say a thank you both for such a wonderful lecture today, but also for all the support and the constructive challenge that you've been able to offer us as we've developed the realistic medicine story over the last couple of years. It's been a huge benefit and really a kind of source of inspiration for us.
It's been a privilege, Gregor. As I said, I made it a point to have the opportunity to spend time with Catherine and with you after reading Realistic Medicine, and it was a privilege.
Well, I've got a question for you today, and it touches upon some of the stuff that you've been able to outline for us. And what I want to do is I want to go back to some of the early writing on evidence-based medicine from David Sackett and his colleagues. And if we look at that, we can see a very clear description that there's three component parts to evidence-based practice, and he speaks about relevant scientific evidence, about clinical judgment, and about establishing patients' preferences and values. I wonder, did we forget about the balance between these elements, and do you think modern clinical guidelines are explicit enough that we should consider all three of these components together?
Great question, Gregor, and I have an answer with two parts, but then I'd love to hear either in the chat or subsequently from those listening what they think. First of all, I think this is related to the comment I made about the conceptual barrier, about what kind of measures that we are comfortable with. David's work in evidence-based medicine grew out of his and his McMaster's team's work with critical appraisal, which was all about understanding the evidence well, and being sure that we were interpreting it correctly, that it was gathered effectively. So there is that background, and the evidence is all about the probabilities largely. As I said, when we studied women with breast cancer facing their surgical decisions, there was this terrible imbalance where 71% of the doctors thought that living without a breast was a top 3 concern, and only 7% of the women themselves did. The men with prostate disease, wide distribution of how they feel, about exactly the same symptom level in terms of their quality of life. Without having that quantified, and it's relatively easy to do, without having that quantified, we're not going to pay a lot of attention to it. And as a result, the guidelines don't pay a great deal of attention to it. I give NICE a great deal of credit. This is the 5th year in which they have a shared decision-making collaborative, and they're really trying to work through this because they recognize that if they don't, we will continue to routinely give interventions to people who wouldn't choose them while we withhold them from people who would. And we do the former much more often than we do the latter. But every time we do the latter, we make people worried about rationing. And we make it more difficult to challenge the assumptions that need to be challenged in order to realize realistic medicine.
Thanks, Al. That's wonderful.
Thanks very much, Gregor. And Al, we've just asked the QI connectors. So what do you think? Is the balance out of kilter, and if so, why? So if we had this fundamental of evidence-based medicine being the scientific evidence, the clinical judgment, and the patient perspective, are they out of balance, and if so, why? So please chat into the chat box if you've got a comment on that or a thought on that. Thanks again, Gregor. I think, Al, looking at the chat box, we've had amazing conversations with Graham Kramer, who's the general practitioner, but also the Chief Executive Officer for patient partnerships at the Royal College of General Practitioners in Scotland, where he was talking and referencing the variation and saying that the variation is further, the atlas of variation is further evidence that high intensity clogs up the system with workload, reduces access, reduces quality without improved outcomes. And with all of his work around the house of care and with his work in involving patients, he's found that to be a common issue. It's fair to say, however, that a lot of the comments in the chat box, we had Erin Walker, who's the Patient Insight and Involvement lead at UCL Partners down in London, saying that she doesn't think that patients know much about the variation in care that's out there. And Jill Booth, who's the Value Program Development Lead here at Healthcare Improvement Scotland, Jill asks a question. She said, I'm curious to understand how patients would know if there was variation. Even with publicly reported outcomes data, it doesn't seem to be commonly used by patients. And if it was used, what difference does it make? Your experience in that field of public reporting and the patients and public using the data, Al?
Yes, I do know a good bit. This is something that Nirav touched on last month as well. Often patients do ignore variation in reporting rates. The early reporting rates in the U.S. were in New York, and a lot of the early research focused on New York State. Patients don't pay a lot of attention to it, and it's largely because they feel so annealed to their primary care providers and to their local community. I think that we are to some extent providing the wrong measures when we try to engage people. If we provide them evidence of deep wound infection rates, for instance, for hip replacement or stroke rates following bypass surgery, they certainly don't want those things to happen. But it keeps the conversation at a scientific and technical level that they don't feel capable of joining. And if we were talking about variation in decision quality, If we were talking about how you can go here and a man who feels really badly about his symptoms is just as likely to have surgery as a man who feels fine with his symptoms, or here, where the man who feels badly is 7 times more likely. In other words, if we had data that patients could relate to in terms of their expertise, and we made that more visible and transparent, I think we would engage them more effectively and more quickly. One of the lead recommendations that Chris Trimble, Glenn Elwin, and I made in Stop the Silent Misdiagnosis was that it would be easy to document prevalence of preference misdiagnosis in different regions, and you could strategically pick high-rate regions, low-rate regions. And what we said is, when you document those, report them loudly. Be transparent about it.
Thanks very much, Al. We've got Akin Akinola, who leads the QI, the Improvement Club at the Golden Jubilee Foundation Hospital here in Scotland. And Akin is a regular QI connector. And he was just wondering about the whole movement in shared decision making, and are there good examples in the US or UK where shared decision making has been adopted? And if so, what are the outcomes, or what are the changes in outcomes?
Oh, there are a lot. There are over 100 randomized trials of shared decision-making interventions in the Cochrane collaborative, Cochrane review. It often decreases utilization of high-cost, high-risk interventions, surgical interventions, almost always increases patient knowledge. When people do look at this value concordance, are they getting the treatment that reflects how they feel about losing a breast, how they feel about their lower urinary tract symptoms? Those things improve. To answer the first part of the question, there have been some institutions, Dartmouth, Massachusetts General Hospital, Group Health of Puget Sound, that have been very effective at implementing shared decision-making, but still in a relatively patchy way, as if it's a research intervention as opposed to something that really is integrated in all of the care processes. Honestly, despite 20, 25 years of efforts to do so, I don't think any place can point to their consistent use of shared decision-making to uncover the true demand for services. That's why I made as a condition of my coming to Dartmouth the opportunity to create a new model of primary care that was designed to be the learning front end. That's why we've been working with NHS and UCL Partners and Right Care and others in England to try and create this mutual accountability. It won't happen unless everybody sees responsibility for performing well in their role to make sure it happens.
Wonderful. Thanks very much, Al. We're coming to the top of the hour here, but just in response to your question about are these various components of the original evidence-based medicine in balance or visible, you know, we've got a number of comments in here and some. So Graham Kramer, the origins of evidence-based medicine were developed in acutely ill people. Its translation into patients or people with incurable long-term conditions has been somewhat misapplied, would be a comment. Erin Walker from UCL Partners again says, not enough balance and not enough evidence-based medicine, but I don't have the evidence to back some of this up. It's a bit of a hunch. And the final point from Kate McCusker, who's a lead pharmacist at the Children's Hospice Association in Scotland, making the point that patient understandable data to guide joint decisions would be a very useful intervention. So just some comments you might want to reflect on, Al?
Yes, no, I do, and probably the strongest reaction I have is that we're talking about transformation of health and care systems globally in order to make them sustainable. And you don't transform with marginal improvement. You transform by experimenting with very different models. And by definition, there's no evidence. So when you're in the transformation, when you're in the innovation implementation space, the absence of evidence isn't a red light. it's a green light. But you have to be held accountable for learning with using rapid feedback measures about whether or not you're heading in the right direction to achieve what you want to for the system and for the people you serve. And that can only be done with disciplined experiments and a risk attitude that recognize that failure is part of learning.
Al, thank you so much. We've come to the end of today's QI Connect. You've left us with a great deal of food for thought, but also a whole series of resources to further our learning. So thank you so much. Just a big shout out again to Al for both signposting both last month's talk with Nirav and also next month's QI Connect webinar with Atul Gawande, widely known to many of you. We are so pleased to have Atul join QI Connect, and of all the things that he could focus on, he has chosen to focus on implementing the lessons learned from Being Mortal, that wonderful study of choices made at the end of life. So we look forward to Atul Gawande's talk, and Atul joins the amazing 2018 lineup that you can see in front of you. So we're looking forward to the rest of the year, and remember, please follow us on Twitter, and a big shout out again and thank you to Al Mulley from Dartmouth, to Gregor Smith from the Scottish Government, and to the QI Connect team. Have a great day. Thank you very much, folks.